WIBD, WMBZ Radio, WTKM Radio, My Community Now, Hartford Times Press, Kewaskum Statesman, and the Milwaukee Journal Sentinel. We will begin with a silent prayer and the Pledge of Allegiance. Please rise. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Our next item on the agenda is the review of the minutes. Did anyone notice anything that needed attention?
Yes.
Supervisor Bailey.
Next meeting date is wrong. It's still today instead of, I mean, it's from last month. Should be the 18th today. You see that? Says the next meeting date is July.
Thank you. Anything else? With that correction, the minutes will stand. Item number 3, items for discussion or possible action. 3A out of home care 2026 6-month financials. And for that, I believe we have with us this afternoon Jen Wilkins and Christine Ulrich.
Okay. Hi, good evening. I'm Christine Ehrlich. Jennifer Wilkins couldn't be with us today. So yeah, I'm here to talk about the out-of-home care budget for 2026. I am one of the youth and family services supervisors over at Human Services. Overall, our out-of-home care spending is tracking fairly close to budget throughout this year through June. We've spent approximately $1.52 million, which is 57% of our total combined out-of-home care budget. Some of the big takeaways would be our residential care is our highest cost in out-of-home care, and we've spent approximately 64% of that. So far, I think a lot of that contributes to the residential placements. Numbers are down, but the cost continues to go up year after year for that daily rate. So while we used to have 13, 14, I think at one point we even had 20 kids in residential care. This year, as of today, we have 8. So we've done a lot of work getting that number down, but the price stays the same. One of the other takeaways is our shelter care. We are at about 53%, and a lot of that contributes to the sale of Riverbend Place, the youth treatment shelter here in West Bend, and we're contracted with Waukesha County for shelter beds. So we are contracted with that for $110,000 per bed annually. Overall, we're not seeing a significant concern with the total out-of-home care budget at this point. While we are projected to be over budget halfway through the year, that's kind of generally where we expect to be. And I just want to emphasize that although that is over, at the end of the year, the overall HSD budget has not been over budget. So it does kind of weigh out in the end. That is our main expenses.
Thank you. Did any of the committee members have questions? Wow, that was an easy report.
Yes.
Thank you very much. Have a good evening. Item 3B, inpatient hospitalizations, 6-month financials update. And for that, we have Mr. Doug Bry.
Yes, thank you. I am Doug Bry. I'm the Behavioral Health Division Manager. As you can see, our trends for this year are running a little bit high for inpatient, and that includes Winnebago Mental Health and Mendota Mental Health. For the first 6 months, the inpatient costs are totaling $832,000 or 69% of the $1.2 million budget. We're running above pace, as I pointed out. A small number of those additional costs are driving up those expenditures. So when someone does go to Winnebago or Mendota, our first plan is to talk about discharge. We're always talking about discharge planning, and it really depends on the acuity, if the person needs placement, if we can find that placement. There's lots of variables that go into that. the individual at Mendota, which is a rarely institution that we use, but it really is based on very high acuity. And we've had a couple of placement options. One has fallen through, and we're currently in process of looking at another placement option in Madison. And then we will also be funding that placement. So it'll shift the cost. It's slightly cheaper, but it will shift the cost off of the inpatient line. And as Julie said in the report, it only takes one or two of these cases to really like impact the budget really strongly. And again, as I said, we always try to get people out. The other piece of these lines are that Medicare, commercial insurance, and Medicaid does cover some of these placements, but they are historically slow payers. We will get Medicare reimbursement back up 6 or 8 months after discharge. And I see those reports, they come from the state. And so those costs are then credited back to us when they get the payment, but the states have to, or the counties have to pay first. And then we get that reimbursement from the insurance. But there's lots of nuances to who pays and what they pay and what age they pay for and what age they don't pay for. But so there is some offset to those costs, but again, that reimbursement is really just depending upon who has the insurance. And some people lose eligibility for insurance when they're in an inpatient facility like that. So lots of variables. The IMD line, we have one person at an IMD right now, and there's ongoing discussions about options for placement. But again, we're just really at the mercy of the acuity. And then if we're going to put somebody in the community, what are the resources available? Also, at the IMD, this person has Medicaid, but when they're admitted, their Medicaid turns off because it's considered like an all-inclusive placement. And so Medicaid isn't eligible to pay for anything. So in addition to the per diem that we pay at the IMD, we also have to pay for meds while the person is there too, because there's no other payer source. So that's one of the other costs that gets added on to that placement.
Thank you. Are there any questions from the committee? Yes, ma'am.
Yeah, I'm a little confused as to why Mendota and Winnebago are not, they are IMDs. Why are they listed separately?
That's the way that's always been done here. I am aware of that too, that they're all considered IMDs, and that's something we have to just change in our accounting system. They're just parsed out differently, but you're right. They all are institutes for mental disease.
What is listed here as an IMD? What hospital would that be?
That's Trempealeau County Healthcare Center. So as you must know, any freestanding facility not connected to a general hospital is considered an IMD.
Over 16 beds.
Yes, over 16 beds. Yes. And when it's an IMD, then Medicaid may not pay. Between the ages of 22 and 64, Medicaid won't pay. Medicare will pay for people who are 65 and older, or people who are disabled and have Medicare before 65.
So these inpatients are just Mendota and Winnebago?
Yes.
Thank you for that question. Any other questions? If not, thank you for that report, and we'd look for you to carry on with the next one.
Yes. As you know, we've been trying to expand services to include veterans that are local Washington County residents for the last couple of years, so they can get treatment locally and not have to drive down to the VA in Milwaukee. Currently, we have between 5 and 10 people, veterans, getting services right now, getting psychotherapy services in the clinic. So we are serving the local population. One of the therapists took it upon herself to want to expand and let people know that we're here for this. And so she took on this initiative where she worked with our veteran service officer, Kurt Roosh, and they created a program where they travel to VFWs and they just informally meet with veterans who will come to the VFW and just talk about our programs and our services. And what came out of that was a more specific initiative. She called it the Guardrail mental health group. It's one of the nice things about being a county is we can do things like this and we can outreach to this population who we may not get reimbursed for those services, but we can at least open them, let the community know that we're here and we can provide services to that group. And so these are starting in October. They're going to be drop-in. They're not going to be considered like a psychotherapy group because we want to stay away from that terminology. It's going to be like a support type setting for veterans' mental health skills to expose them to healthy coping skills. And the hope is that will parlay into them reaching out for more robust services. So if we can just make this non-threatening environment where veterans can come, where other veterans are, and there's a therapist there, but we're not there to actually provide therapy. We're just here to provide a supportive setting. And tonight, actually, Teresa, the therapist, and Kurt are going to the Hartford VFW to just be there and be available to let veterans know we're here. We're available. We're credentialed for the insurance providers for veterans. So we're here and we can provide services locally.
Any questions from the committee? Sir,
So I work for the VA hospital
Mm.
in the mental health division. So this is very nice, and I am going to talk with division management next week and just see we can put this out to the therapists, and when they see a veteran that is from Washington County,
Please.
you
Yes.
know, give this to them. And I plan to visit. I plan to go to that first meeting on October 5th.
Oh, excellent.
So this is
Okay.
great. This is great. You're doing this.
Yeah. We went through all the proper channels when we wanted to start serving veterans a couple of years ago. We went down to the VA, Kurt and myself, and one of the supervisors who manages the case management team went down and we met with leadership at the VA in Milwaukee just to get them on board and really get their like blessing and approval that we just want to like have a add-on service. Like we're not trying to, block anybody getting services at the VA, but we'd like to be able to serve people right here. Even though the VA is fairly close, it still can be burdensome to have to go down there.
Yes.
So
No, I agree. This is great because I mean, if veterans are like, hey, I have to make that 35, 40-minute drive
Yep.
for my appointments, but hey, here's a cool support group
Mhm.
5 minutes from my house once a
Mhm.
month where, I can meet up with people that have an understanding of what they've been through.
Mhm.
So,
yeah,
no,
we're
great.
we're really excited about it. I really think with what we've already established for getting credentialed with TRICARE and credentialed with community care, that we can provide that service right here at the county with our therapists. So we're hoping that will, help with this initiative.
That's great. Thank you.
Yeah. Any other questions?
not really seeing any. All right,
All right.
we'll move on. Thank you.
Mhm.
Item 3D is West Bend Police Department co-response pilot update.
Yeah, so I know you guys have gotten some updates on this from Julie Driscoll on a monthly basis that we've been doing this as she outlines. We came to the table with the chief and one of the captains in November and came up with doing a pilot. And we meet every month and we look at the data, both actual data from our system and anecdotal data from the crisis staff who are doing the ride-alongs and the patrol officers. And we got positive feedback really within the first meeting. We set it up a little bit differently than our crew is set up right now, our crew teams. But I think that's the nice thing about this is we can, meet with a law enforcement agency and do what we'll think will work best for them. And so coming together and creating this, there were ACS or acute care services crisis staff who were interested. So we opened it up and said, who wants to do this? You're gonna be embedded with law enforcement and do a ride along in West Bend, and we're gonna gather data. So we met a couple weeks ago, and at this point, as Julie wrote in the report, we feel really good about what the data that we've gathered. There's really good feedback from our staff and from patrol officers. We gather data on how busy the staff are. As you know, West Bend is our biggest customer here. They're our population center. And so there's plenty of work to keep somebody busy on a shift. And if there's not new calls coming in where someone might be having a mental health crisis, then they fill their time doing follow-ups and checking up on people they've seen before. So right now we're in talks to dedicate 2 crisis clinicians at the West Bend Police Department for 40 to 48 hours. They would remain our employee. That would be their home base where they were working. They would be out in the community. They also attend the roll calls and the briefings that law enforcement goes to. So they're embedded completely on the front end. And they have a workspace where they can work over there if they're in between calls, where they can log on and get into the our electronic health record. They can also do that in the field. And that's also been very helpful for them if they can access information right in the field to help, advise their or inform their intervention with staff. So it continues to be a really positive pilot, both by patrol officers and crisis staff. So we continue to meet. We have another meeting scheduled, but we are going to move forward with something more formal. We just could not see any reason not to make this an actual formal initiative at this time. So we're excited about what that's going to lead to. And Julie outlined how we're going to do that, what that will look like. And I think the thing that it's important of why this is different is it's just an extension of what we already do. So law enforcement and crisis staff already converged on these cases, but it was separate. And I think embedding them and having them respond at the same time has just proven to be very effective and really best for the clients that we serve. And a little bit of data I pulled before I came up here is that 76% from January to June, 76% of the cases they were dispatched on were handled in the community, in the setting they were in. So no need for hospitalization, no need for any more intensive services. It was handled in the community, and the person was allowed to stay in their home, or they created a safety plan with a loved one or a caregiver. And then they would do follow-up contacts the next day or two. And in that 6-month time span, there was only 4 emergency detentions. So that's a great number because we want to keep people in the community as much as possible. There are times when that's unavoidable. And so we have the capacity to do the emergency detentions, but 4 emergency detentions in our population center is a really good number for us. And there's a varying other hours. They spent 87 hours doing assessments, 73 hours doing follow-up assessments, and then other activities. So it continues to be a positive initiative, and we're going to continue moving forward with it.
Thank you. Are there any questions from the committee? Starting with Supervisor Trout.
I'm just trying to refresh my memory. This was started because West Bend had not been, the police department had not been utilizing this as much as what they maybe could have. Is that?
Really, it comes down to dispatch. They didn't have shared dispatch. So our crew officers would not know when a call came into West Bend. And since we are located in West Bend, the crisis staff, it was just as easy for them to call us and we would just go out because we're right here. So I don't know if it was a matter of not using it as much as it was the system that we had in place met all their needs. And so in trying to talk with them and expand how we can even improve upon that, that's how we came up with this initiative.
Okay. And I'm gathering that it's been much more successful doing it this way.
Yeah, it's been, and I think what we learned from this is that there is no exact one way to do this work. I went to a training with Julie Driscoll and the crisis supervisor a few years ago in Indianapolis, and what we took away from that conference was that there are many ways that states are doing this, or counties or cities are doing it. Some just have a crisis worker at the police department, and they dispatch on their own to calls. Some do what we're doing with West Bend. Some do what we're doing with crew. So there's lots of different ways to do it. When we went forward with the crew, we felt like this was the best way. And now with what we're doing with the West Bend, I would say that this is just as good, that one is no better than the other. They're just different. And given crew's large jurisdiction, given it's the whole county, I think that model makes really sense for the sheriff's office. And I think this model makes really good sense for a more compact, like, municipality or jurisdiction.
Great, thank you.
Other questions? Yes.
The 40 to 48 hours, that's divided between the two clinicians?
Yes,
Not each.
correct.
Anyone else? Well, I've got a couple of questions then. If there were 4 emergency detentions in that 6-month time period, what would have been typical? And this is an unfair question. You may not have the stats with you, but what would have been a typical rate or incidence of detentions earlier?
I don't have. What I do have is what our detentions have looked like over the last 5 years.
Okay.
In whole,
Yep.
not by jurisdiction. So last year we had 177. And back in 2021, we had 185. And then the highest we had from our data was in 2023, we had 214. So they are trending down from 2023. We had 189 in 24. As I said, 177 in 25. And this year, through when this data was pulled, which I'm not sure if it was pulled through July or June, we've had 86. And so we're on pace for about 144, which again would be a decrease. So it's very hard. We could get at the data of where the person, was when we did the detention, but we don't typically track that. We can do it, but 4 in 6 months, less than 1 a month, is a really good number for us to have. But to answer your question, no, I don't have exactly what would have been different before.
And then you probably mentioned, I must have missed it, but is there fundamentally any difference between what the crew units are doing with the city and the just different methods of contacting
Yep.
people?
Yep, it's just different. They arrive on scene together. So there's no difference. It's just how the calls come in and where they come to, but they still arrive together.
Very good. Any other questions? Thank you for your reports. Appreciate it.
You're welcome. Thank you.
Item 3E is the ADRC quarterly report. Welcome.
Thank you. Good evening. I'm Tammy Anderson, the Director of the Aging and Disability Resource Center. So the report that I provided you with today is a mid-year. So this is January 1st through the end of June. What's exciting about this for me, probably not for you guys, but we just transitioned to a new database. And so we really are able to pull some more interesting data. This report is kind of a snapshot of numbers of people, but what I am looking forward to reporting in the future, we just started July 1st time tracking within our database. So that will really be able to give us a much better picture of how long cases are taking us. We know some things may take 1 or 2 contacts in the services we're providing. And we know there's some cases, I can think of a recent case where we probably spent nearly 40 hours helping one person get connected to services and supports in the community. So I don't have any of that data to report. Like I said, it just started July 1st, but I am excited about bringing that forward. So I'm just going to briefly summarize some of the information that I provided. I broke this down into our core services, as you can see on the report. So those bold headings, aside from our mission statement, are programs. You can kind of think of them as like divisions or programs within the Aging and Disability Resource Center. The information and assistance team being the biggest one. There is 6 members of that team and 1 supervisor. And in the first half of the year, just doing a one-off contact with somebody, so somebody calling into our agency for a phone number, a housing list, something like that, we serve just over 1,000 unduplicated customers. So that's unique individuals. And in addition to that, when somebody is calling us, it may require multiple contacts. It may require follow-up planning. It may require going out to their home, collecting collateral data, that sort of thing. So in addition to that 1,000 unduplicated consumers, we served another 366 consumers, which was multiple contacts. So that would be something that will hopefully show in our upcoming time tracking report, that those are the cases that are taking multiple hours by one staff person, in addition to all the other duties that they're doing within the agency. Aging and Disability Resource Centers are responsible for enrolling people. We are the point of contact for enrolling people into publicly funded long-term care. So if you are, I think I said this to the committee last time, if you are out of funding, but you need services and support either in your home or you need to go into a community-based setting, we are the place you have to contact. And we enrolled 179 consumers into a long-term care program in the first half of this year. Our benefits counseling team works on all things that have to do with insurance, private insurance, government benefits. So think Medicare, Medicaid, kind of cutting through the red tape of all the problems that insurance companies can bring. Our disability benefit specialist, so she works with people that are adults under the age of 60, served 228 unduplicated consumers and 117 of those were new. She is 1 staff member, has 2 support staff that kind of triage the calls coming in or schedule calls coming in, but she has 1 staff member that is highly trained to provide those services. And then our elder benefits specialist, I did note the reason for the larger number of consumers between those 2 programs is the way in which they document in the system, but very close. She served 131 new clients in the first half of the year. Any questions about any of those numbers or any comments?
I'm just curious, are the numbers of new consumers increasing at all, or are they pretty flat from year to year?
Yes, I don't have any data that I can provide to you to show you that increase, but I can certainly bring that to a future meeting. Yes, I mean, we have a huge population of particularly older adults that is just growing. And in this county, it's a beautiful county to live in. It's not quite the city. It's not quite the country. So yes, and I was appointed as part of a work group through the state of Wisconsin. One of, I believe there's about 12 of us in a group that are really looking at the growth of the population in Wisconsin, particularly with older adults, and how we're going to manage that growth over the next several years. So we have a large group meeting coming up the end of September. And so I'd be happy to report some of those findings and things that we are working on to create efficiencies within the statewide network.
That would be interesting.
Yeah.
Supervisor Wolf?
Yeah. How far back does that data go? If you were to show trends over years, right? How far back did you?
I believe when we transitioned the database, they kept 5 years of data. If I wanted to pull further back, I think I need to contact somebody at the state that may have some archive files that I don't particularly have access to.
So you get a 5-year.
Yes,
Yeah. Okay.
yeah. So I'd be happy to pull some data over the years.
And Supervisor Stewart.
Thank you. Kind of what you're saying is the future of our aging population in the county. We can piggyback off of our board meeting on Wednesday. We were talking about the consolidation of EMS services. And Aaron Dahl had already done the graph, and Dave Seeger, showing the trend for the aging population is going up. You know, so I think looking at the numbers that we already have and then trying to then see if you can go back up to 5 years and maybe we could find out the average cost per person. And then we can anticipate with the growth of this population, which is already what we're leaning towards with the numbers that we saw at that meeting. And then we can help anticipate with the average cost per person. And then the numbers, the trend of numbers that we know is going to go up. And then we can kind of anticipate that cost in a long-term budgeting plan.
You should join my state work group. Those are all the things that we're looking at.
Yeah.
I mean, I'm saying that jokingly, but
No.
those are great data points.
Yeah.
I can bring them specifically for Washington County. If anybody's interested, the Wisconsin Department of Health Services has some really great data and maps on the aging population in Wisconsin. So that's just interesting data to look at in general. And there is a return on investment calculator that I have never been able to work properly. I need to tap into the data person at the state that really shows for every dollar you're investing in ADRCs, what is the return on investment to community members and taxpayers? Because ADRCs are helping people stay in the community, stay in their homes longer, which is a much less or much more cost effective than shipping people off to facilities and paying high costs for things that aren't really needed for them. I'm going to try and get that return on investment thing working. The last time I pulled it, it was a negative number. I was like, that cannot be accurate. So, but those are all the things that our work group is looking at. I'm part of a subcommittee of that work group right now that is working on a document related to operational efficiencies. So I chose not to join kind of the dollars work group, that data dollars work group, but we put together like a 5-page document looking at, in the event that you're down 1 staff member, what can you do? In the event that you're down 3 staff members or you have a big economic downturn, what can you do, all the way down to like emergency operation type functions. So it's been pretty interesting and I'm really enjoying it. So I'd be happy to bring some information to a future meeting.
Yeah. Or feel the email some of that data. I like looking at it.
Okay,
Yeah. Thank you.
you're welcome.
Thank you. Any other questions?
There were a couple more numbers on there. Put in some numbers for our senior dining program. That is the program that provides either congregate meals to people that are not homebound or home delivered meals to those that are homebound. The numbers in here just on average work out to be about 150 meals per day that we're serving. Most of those in a home delivered setting. That is a downtrend from years past. We were serving many more meals pre-COVID, and we think that COVID has a lot to do with people not tapping into those services as much as they potentially could, and some of the options that people have for getting meals delivered to their door and things like that are just a lot more available than they were years ago. Our health and wellness programs, I was not able to pull any great numbers, but I will get you that in the future. So not only does our agency provide health and wellness classes to the 60+ population, we also partner with the senior centers and community centers. We provide them with a reimbursement for programming that they're providing, and I just couldn't gather a great number for that would have been meaningful. So I'm going to work on that one. And then we have a dementia and caregiver support. So our dementia care specialist assisted 59 individuals. The majority of those individuals are caregivers in our community. So of 117 caregivers in our community, we're served with either resources, some sort of support, and a large portion of them, some funding that we're able to provide them to get a break from their caregiving duties. Any other questions?
Are you oh, go ahead.
Oh, I have one question on the senior dining.
Yes.
I remember back, in 2020 or after that, and there had been a big, I think you were trying to find more places where you could serve meals and, trying to find more sites because of the downward trend. Are you still looking for that or?
Actually, due to our numbers, probably about 2 years ago, we closed one of our sites. We were in a subsidized apartment building in Kewaskum, in which the population was really turning from older adults to kind of that younger mental health population. We had 1 to 2 diners at most, and that was not the population that we can even use the funding for. So because of that, we combined that site with our West Bend site, maybe 10 minutes away. Very easy to still get the meals out. And we are currently looking at potentially combining 2 of the sites. So we're actually trending towards closing more sites, but not serving less people. So a manageable site would provide anywhere from, I'd say, 30 to 75 meals. That would be manageable for the meal site manager that's on staff there. And we do have sites that have like 10 to 12 meals. Another site that maybe has 30. And so we're really looking at, from a cost reduction as well, saving those staff costs and mileage costs and things like that upon somebody's retirement, potentially combining sites. So that is something that our nutrition and wellness supervisor and I sat down about a year ago and started future planning, kind of look 5 years out. What are some of the things we can do to reduce costs? First, what are some of the things we can do to increase meals? And when we're not seeing that happening, then what are we going to be able to do to reduce costs without really reducing services? So at this point, we went from, in my time, this month is my 10-year anniversary with the ADRC, we went from 7 sites to 6, and then that kind of potential of looking at combining sites in the future.
That makes sense.
Yeah.
Thank you.
You're welcome.
With regard to the dementia and caregiver support, are most of the caregivers family members or? are they-
Yes.
Okay,
Yes, most of the caregivers that are coming to our events and calling are family members, typically spouses, but not always, sometimes adult children as well.
thank you.
Mm-hmm.
Any other questions? Thank you for your report.
Thank you.
Thank you.
Sure appreciate it. Our next meeting date is September 15th at 4:30 PM. And I wanted to let the committee members know I will be absent that time, so I'll have to, I'll work with the vice chair for setting up the agenda in conjunction with Mike and his team. Also, the torch trophy back there is the American Heart Association right here. My workplace has been honored with hosting the torch for a couple weeks, and I thought I'd bring it in this evening. The American Heart Association Heart Walk is in late September, September 26th, down at Summerfest grounds. If you're interested, here's a little bit of information about that I thought I'd share today. So, yeah, you're welcome. We are adjourned. Thank you for your attention and your